Evening to all of you. On behalf of the Association of National Board Accredited Institutions and on behalf of the speakers, it's my pleasure to welcome all of you to this webinar, the fifth in the series of the tendinopathy webinars. A little bit about the Association of National Board Accredited Institutions. This is the first webinar we are doing with ANBAI. The earlier one was done with the AHPI. ANBAI is an association of all the postgraduate teaching institutions under the NBE. We have state chapters across the country and work very close with the National Board of Exams, work very closely with them, both in policy and in collaboration. And we try and ensure that the quality of medical education, postgraduate medical education in particular, is maintained. Our president of our association is Dr. Harvinder Chabra. I'm privileged to be a founder patron, and we have with us today Dr. Ravindra Chahal. He's our academic coordinator, and he'll be speaking towards the end of the program. On behalf of ANBAI and all of us, I want to thank Farmed, who is actually helping us, supporting this webinar. They've done a lot of background work to ensure that we have a wide reach. And with ANBAI, in addition to our regular audience, we are sure that in this conference we have postgraduate students and junior consultants. So very quickly before I hand over to Santosh, we'll start off with the webinar. After I hand over to Santosh, we have the three eminent speakers known all over the country, Dr. Madhusudan, Dr. Ajit Tiwari, and Dr. Praveen Barduraj. They'll speak for about 8 minutes each, followed by a case-based discussion, which Dr. Santosh will moderate among the speakers. And this will be followed by the last session, which is a very important session, the question and answer session. Again, this will be moderated by Dr. Santosh. And we'll end the program with a vote of thanks on behalf of the Association of National Board Accredited Institutions by Dr. Ravindra Chahal. With that, I hand over to Dr. Santosh to take forward the proceedings. Over to you, Santosh.
Good evening, everyone. And coming to today's topic, it's wrist and hand tendinopathies and evolving with experience and the evidence. So what does the evidence say? What is the experience of our speakers? And all are well-renowned speakers here. Coming to the first topic here, which comes is recognizing the wrist and hand tendinopathies. So diagnosing a hand tendinopathy is more important, and Dr. Madhusudan, who is a hand surgeon in Bangalore Baptist Hospital and Manipal Hospitals of Bangalore, North Bangalore, and an editorial board of Hand Surgery, Journal of Hand Surgery, he'll be starting our presentation today with his talk. I hand over to Dr. Madhu.
Is my screen visible now?
Yes.
Yeah, thank you. So good evening, everyone. And thank you, Dr. Alex, sir, for this opportunity. You have been my teacher, mentor, and a constant support throughout my academic journey. So today I'll be discussing on recognizing wrist and hand tendinopathies and avoiding common pitfalls. So tendinopathies around the hand and wrist are one of the most common encountered complaints evaluated and treated by hand surgeons. Yet, despite advances, they are often missed, mislabeled, or mistaken for something else. Many of these patients go through a maze of diagnoses like arthritis, TFS injury, and whatnot before the tendon finally gets blamed. The problem is not that these conditions are rare. The problem is that the hand is mechanically complex, anatomically crowded, and clinically deceptive. And most importantly, the hand is a perfect setup for tendinopathy. And that is the price what we are paying for the precision we are having. Too many tendons, too little space. Multiple tendons are crowded within these tight osteofibrous tunnels, which predispose them to friction and impingement. The tendons crossing paths. The crossing of these tendons will increase the shear force at the point where they are crossing. Next, bending under pressure. The tendons doesn't run in straight lines. Usually they bend around the pulleys or the bony prominence. This is an example where the EPL tendon is bending around the Lister's tubercle. The pulley paradox. The digital pulleys, though they are designed for the smooth movement, sometimes they are the stenosing points and the setup for the trigger finger. Then the cost of repetition. The hand is a victim of its own efficiency. The continuous movement and gliding cycles lead to small microtraumas, failed healing, and finally, the tendinopathy. And finally, the synovial sheath. Though they are designed for the smooth gliding, sometimes they might get thickened and increase the resistance. So with that, we'll discuss on the decurrent stenosynovitis. So as we all know, the extensor tendons of the fingers and the wrist are divided into 6 compartments over the dorsum of the wrist. The first compartment contains the abductor pollicis longus and the extensor pollicis brevis. And the inflammation of this compartment is what is called the decurrent stenosynovitis. The pathogenesis is multifactorial. The repeated supination, pronation, as well as labor-related microtrauma are the important contribution. And these conditions are also commonly seen in females and during the pregnancy, suggesting hormonal influence. Anatomic variations are the most important, and this suggests why some patients fail conservative management. One of the most important anatomical variation is the presence of intertendinous septum, where the EPL and the APL and EPB are in the separate compartments. Next, the multiple slips of APL. This is one cadaveric dissection which is showing almost 11 slips of APL. Then the insertion variations of these tendons, especially the EPB, which alter the tendon mechanics and contribute to these symptoms. And finally, the presence of a bony ridge within the tunnel, further reducing the space for the tendon gliding. The biggest pitfall is that we believe that most of the radial side wrist pain are decurrent stenosynovitis, and it's not. The tenderness in decurrent stenosynovitis will be around and over the radial styloid region, whereas the tenderness in first CMC arthritis will be distal to the radial styloid. There is another condition called as the intersection syndrome, which we'll discuss in detail shortly. And here the tenderness will be 4 centimeter proximal to the Lister's tubercle. And then we have a condition called as the Wartenberg syndrome, which is a compression neuropathy of the superficial branch of the radial nerve, where the symptoms or the tenderness will be in the mid forearm on the radial border. Coming to the test, there are several tests described for decurrent stenosynovitis. Firstly, the Finkelstein test. This test has been misquoted and as a wrong description has gone into most of the orthopedic textbooks. The original Finkelstein test, you hold the patient forearm with one hand, and with the other hand, you hold the thumb and give an ulnar deviation, causing ulnar deviation of the wrist. Since this test is painful, Dr. Mudgal and team has come with a staged Finkelstein test, where first you ask the patient to actively ulnar deviate the wrist. If patient is having pain, you stop there. If the test is negative, you go to the next step where you hold the hand and ulnarly deviate the wrist. Again, if patient is having pain, you stop there. And if the test is negative, you go to the last step where you hold the thumb and ulnarly deviate the thumb. If that is the Finkelstein test, then what is this? Because this is what we routinely or commonly do in the OPD. This is not Finkelstein test. This is the Eickhoff maneuver. As name suggests, this is not a test and it's a maneuver described by Professor Eickhoff to show his students how the pain of decurrence will be and where exactly it will be felt. Next is the Watt test, the wrist hyperflexion and abduction of thumb test, where you ask the patient to actively hyperflex the wrist and abduct the thumb against resistance. If positive, the pain will be felt over the radial styloid region. Then you have the EPB entrapment test, which is the only test which indicates whether there is a separate subsheath for the EPB. You ask the patient to extend the thumb as well as abduct the thumb against resistance. If the thumb extension is more painful than the abduction, it indicates that there is a separate subsheath and which needs to be surgically released. And finally, the tethered thumb sign, where the patient keeps the hand or the thumb extended when you take the wrist into ulnar deviation. Ultrasound are very useful in terms of they can detect the intertendinous septum, sometimes the multiple slips, and also tendon thickening. Next, we'll go into the intersection syndrome, which is the tendinopathy of the second dorsal compartment. It has been called with multiple other names. So it is a tendinopathy of the second dorsal compartment as the first dorsal compartment crossover. And that crossing over happens at least 4 centimeters proximal to the Lister's tubercle. These patients usually present with the pain with wrist flexion or extension with associated swelling and often seen in patients who perform repetitive wrist motions.
I just want to know where 50 units, 50 units in
The ultrasound or MRI are diagnostic, which shows effusions and peritendinous edema in the region of crossing over. Next, we have the trigger finger, which is one of the most common tendon disorder in the upper extremity, affecting of almost 2% of the general population. The cause is the friction between the tendon and A1 pulley, leading to thickening and inflammation of the pulley and the tendon. The incidence is more common in females, diabetics, and in patients with rheumatoid arthritis. The diagnosis is made clinically where you can localize the pain to the A1 pulley region. Sometimes there might be triggering or locking of the digit, and you can always palpate for the painful nodule. So the final thing is on the ECU tendinitis. So this is, see, whenever the wrist pain is there, we divide into radial sided wrist pain, which includes the decurrent stenosynovitis, CMC arthritis. Then you have central wrist pain, and then finally the ulnar sided wrist pain. And ECU tendinopathy is one of the cause for the ulnar sided wrist pain. The ECU is particularly at risk mainly because of its anatomy. See, first of all these tendons are segregated into different compartments. And upon that, ECU is having its own subsheath. That is one. Second, during pronation, the ECU is in straight line. But when you supinate the forearm, there is angulation of almost 30 degrees, which increases the contact pressure of these tendons. Usually seen in ball and stick sports such as tennis, golf, hockey, and patients present with pain localized to the sixth dorsal compartment, which worsen with forearm supination and wrist flexion. Why in supination? Because the ECU is an ulnar deviator of the wrist when forearm is in supination, and it's a prime extensor of the wrist when the forearm is in supination. Sometimes the patient might have some dysplasia in the region supplied by superficial branch of the ulnar nerve only because the nerve is running very close to the ECU tendon. Coming to the differential diagnosis, no much differential diagnosis. One is ECU subluxation, and another one is a TFCC injury. In case of subluxation, when you ask the patient to supinate and pronate, you can easily see the subluxation where the ECU tendon comes out of the groove of the sixth compartment. Sometimes even you can hear an audible snap. TFCC multiple test. We are not going into details now. But one test, what you should remember, and today's take-home test is the ECU synergy test. Now let us understand why the traditional ECU test is flawed. When you ask the patient to extend the wrist to check for the ECU, it's not only the ECU which is acting, because there will be all the other wrist extensor which are acting together. So somehow you want to isolate the ECU, and that is where the brilliance of the synergy concept comes. I'll explain you with the test. You ask the patient to flex the elbow and supinate the forearm, and then ask the patient to abduct the thumb against resistance. So normally, when the thumb is abducted, the wrist has to collapse into radial deviation, but that doesn't happen mainly because of the stabilizing effect of the ECU. Here, you are not extending the wrist. So all the other wrist extensors are not acting, but you are utilizing the stabilizing effect of the ECU, and that's how it helps in knowing whether ECU is involved. And then you apply this in the clinical algorithm. If ECU synergy is negative, think of an intra-articular pathology. If that is the only test which is positive, likely ECU tendinopathy. If that is positive along with the other provocative test which I just showed, then it could be combined pathology, which is like TFCC. Thank you. Thank you for your patience.
Thank you, Madhu. That was an elaborate discussion about what we regularly see in our OPD. And I think once the proper diagnosis is very important to be made, and then you can think of doing what needs to be done. And hence, coming to next presentations, Dr. Ajit from Kanpur, who is recognized as one of the very good teachers in hand surgery. So he will be dealing with the medical management of the tendinopathies around the wrist. So he also will guide us on some injections, which he will be showing in his topic. Over to you, Ajit, sir.
Okay. Is my screen is visible? Not yet.
Stop sharing mine, sir. I think it will be visible
Yeah.
now.
Is it visible?
Yes, sir.
Yeah. Okay. Thank you. Thank you, Madhu. Thank you, Alexa. And thank you all for giving me this opportunity. So, Madhu has described very well about all the tendinopathies around the hand and wrist. Let me talk about uh, medical management or conservative management. So, this is my disclosure that I don't have any association with any kind of pharma or discipline companies. So, as Madhu has told that these tendinopathies are the chronic localized pain and they causes functional impairment and often associated with the repetitive mechanical loading. So what are the common tendinopathies? Trigger finger thumb, recurrence, issue tendinitis, FCR tendinitis, intersection syndromes. So the first line of the treatment of all tendinopathies are the non-surgical treatment. They can be managed by the medical management or some local injections. So I think first and foremost thing is that we should always consider medical management. Then if it doesn't work, then probably we should go for the surgical management. The basic principle is that to reduce the pain and inflammation, promote tendon healing, restore function, and prevent recurrence. So there are three modules of the treatment of the tendinopathies as far as the conservative treatment is concerned. One is the rest and splinting, another is the NSAIDs, and third is the injections. When patient is presenting acute, means that someone has a tendinopathies like pain and kind of tenderness or trigger or decurrence. These tendinopathies, if the patient has since last 10 days, 1 week, are in acute situation, then probably we should go for the rest and splinting with or without NSAIDs. So acute situations can be managed with the rest and splinting and NSAIDs, but when this condition becomes chronic, it's not acute and it cannot be managed by the medical management or the splinting, then probably we should go and consider the injections. The medical management, as I told that there are reasonable options for the acute pain, but there's no clear evidence that the NSAIDs are effective in the chronic tendinopathies. Let me talk about the special particular conditions like trigger finger. How to proceed to manage this trigger finger? The first and foremost thing is that we should tell patient to do the activity modification. Many a time the patients have working on their desk job and doing their computer typing and all those things. So we should always tell them that to do the kind of activity modification, not going in one go, and then probably we should go add the NSAIDs with that. Splinting is a good mod for the treatment of the trigger finger. We can immobilize the TIP joint, PIP joint, and MP joint. Majority of the time, immobilization of the PIP joint is useful because the flexor tendon doesn't glide, so the tendon get rest and the swelling and edema, whatever is there, that will be settled down. So injections is a very good modality for this kind of tendinopathies, and the 60 to 90% resolution of disease happens because of the injections. What what we'll see in the ultrasound that in 3 to 4 weeks, the A1 pulley sizes decreases. The thickness of the A1 pulley decreases in 3 to 4 weeks after the injections. How many injections? Probably the 2 injections are recommended at the gap of 6 months. You might have seen that the people are giving injections alternate days, 5, 6 injections. So those things are not recommended. Something which is most important is that we should not give more than 2 injections, and these injections also at the gap of 6 months, not before that. It is less effective so there are few patients whom injections are not very effective, like diabetic patients where they have the metabolic syndromes or the rheumatoid arthritis. So these kind of patients, they are these patients should go for the surgical intervention or the surgical treatment because injections may not work for them. So what should be the cocktail? It's a 1%, 2% lignocaine, and you can add with the triamcinolone. So there are multiple options. You can add the triamcinolone, you can add the depomedrol. So what is the advantage of the triamcinolone? So triamcinolone is basically, it acts faster, but the duration is less. While the methylprednisolone, it takes time to be effective, and the effect persists for the longer durations. How much? It's 1 ml each of both either methylprednisolone or the triamcinolone with lignocaine. So the total 2 ml we can give. Where to give? Should be intratendinous, intrasheath, or the extrasheath. Certainly, it should not be intratendinous. It should be either intrasheath or the extrasheath. And what literature says that either you are giving in the intraseat or you are giving extraseat, the outcome is not going to change. So it's not necessary that you should always be inside the intrasheath. So where to give? The patient where the patient has a maximum tenderness. So the point we should palpate before giving injections, we should make sure that where the patient has a maximum tenderness and the place where we should give. Other thing is that the ultrasonography is really a good modality to give injections because you'll be more precise and the outcome will be better rather than the way. So as Madhu has told that the decurrent stenosynovitis has many times they have the multiple, APL has multiple slips and EPB has multiple compartments. So if you're giving, if there's a multiple compartment and you're giving injection to only one compartment, probably it will not be effective and patient will not feel better. So that is why the ultrasonography has a better role in these kind of conditions, especially in the decurrent stenosynovitis, where you have the multiple compartments or the multiple chambers. So you can you can say that the single compartment and you can give injections over here. But if there is a multiple compartments, you should give in the both compartment. Otherwise, patient will not feel benefited. As Madhu has told that the EPB entrapment test, this is very important test to know that there is multiple compartment of the EPBs there or not. So it is a resisted extension and resisted abduction of the MP joint of the thumb. If the patient has a more pain in the resisted extension, it means that the EPB has multiple compartments. This is also important. This test is also important for the surgical management because if you are aware that there's multiple compartment, you should always check it that and release all the subcompartment. Otherwise, patient will not be benefited. Thumb spica splint. This is a method of immobilizing the. It gives rest to the extensor tendons and first compartment extensor tendons. Patient will, as the swelling will be reduced and patient will feel benefit. You can add the NSIDs with that and along with the activity modifications. Here's a small video. You can see that the how to give injections. So hand is such organ that you should be very careful about the infections because if you're giving injection and patient is developing infection, probably it is not excusable. So make sure that the injection should be given in the fully sterile manner. So make sure that there should not be any infection. Any infection by the injections. So I prefer to clean the whole hand rather than the part only where I'm giving injections. So I make sure that the whole hand should be properly cleaned by the betadine and followed by the chlorhexidine. After cleaning the hand, and sometimes you can use that the no touch technique, but you have to be very precise that you should not touch any other thing while before giving the injection. So take the 1 ml of the lignocaine along with the 1 ml of the triamcinolone or the depomedrol, whatever you want to give. And then before giving the injections, clean with the chlorhexidine also. So this is a triamcinolone. And after loading this, clean with the chlorhexidine, and then you can give the injections. So where to give injections? How to know that you are in the tendon or you are in the sheath or you are the extra sheath? So when you are giving the injections, you will feel that you will not able to give because you will feel that you're not able to push the medicine when you are in the tendon. But withdraw it little bit, and where you feel that there is give way, it means that you are in the sheath. and give the injections. And you can feel also that there's some kind of swelling along the seat. It means that the medicine is spreading along the seat. It means that you are in the intra-seat. And then mobilize the patient so that the medicine should be uniformly distributed along the seat. And so this is where we should give injections. So combining injection and the thumb spica cast, the functional outcome is superior than the injections alone. So you can combine thumb spica along with the injections. ECU tendinitis, as Madhu has told, that we can initially you can try with the immobilization by the splint and NSIDs and the injections. But the rehabilitation is also very important. We should go for the isometric exercises, and you can include the ultrasound inophorosis or some kind of cupping, and then we can get. What are the complications of the injections? Local pain, hypopigmentation. This is very important complication. We should always say and tell to the patients that, because many of the patients, they have apprehension because it looks like Hansen disease. So many of the patients has apprehension after developing this kind of hypopigmentation. This is more common, especially in case of the dark color persons. And we should always counsel them that after injections, you may develop hypopigmentation, but it will go within 3 to 4 months, and they should not be worried about that. So this important piece of information we should always carry after giving injection to the patients. Infection, always a possibility. Tendon rupture, as I told, that if we give multiple injections, patient may land up in the tendon ruptures. Increase of the blood sugar, because this is the steroid. If the patient's blood sugar is not very much controlled, probably we should avoid giving injections. So, and to summarize that, the corticosteroid injections are important options, especially in the failed conservative treatment. Although surgical treatment is an elite options, but steroid injections give time to the patient to prepare his mind for the surgery. So whenever any patient of the tendinopathy is coming to me on first visit, I never tell them about the surgery, because you know that we always have apprehension about the surgery. So I always give option of the conservative treatment in the form of the splint or medications or the steroid injections. So after some times, when the patient will be concerned about the surgery, when the patient will make mind about the surgery, then we can go for the surgical treatment. Thank you so much for your patience here.
Thank you, sir. Thanks a lot. Thank you for that elaborate video which you mentioned about how to give an injection, and it was very nice to see how precautions you take so that no infections occur. And
Thank
now,
you, sir.
now since you have finished talking about the conservative management, now the next questions for most of our doctors will be, what if this fails? What next? So I think Dr. Praveen Bharadwaj sir, who's a renowned hand surgeon in Ganga Hospital, and he will be giving us few options of surgery, what can be done in tendinopathy, hand tendinopathy. Over to you, Praveen sir.
Thank you, Dr. Santosh. Yeah, is my slide seen over there?
Yes, sir, it is seen, sir. You are also audible, sir. Thank you, sir.
Good evening, everyone. So I will be talking about when surgical treatment fails after these two beautiful talks by Madhu and Ajit, which make my work very easy. And it is quite easy for me to say, when surgical treatment fails, we need to do surgical release. Though theoretically you could go for a open release, endoscopic release, or a percutaneous release, but by far in tendinopathies, it is the open release which is commonly practiced, and it is also my preference. The three common tendinopathies which we have discussed till now: trigger finger, extensor carpi ulnaris tendinitis, and dequerens disease. We will talk more about dequerens disease because that is the main thing what everyone would be seeing in daily practice, with main emphasis on how to avoid problems when you are doing the release. ECU tendinitis is a very unique sort of tendinitis, because in this, though we release the sheath, but we should always reconstruct the sheath. So this is one point which we need to remember about the ECU tendinitis, because rest all tendinopathies, when we release their sheath, we don't reconstruct them, but ECU sheath always must be reconstructed. Trigger finger is one of the easiest operation in hand surgery, but I would suggest everyone that not to take it lightly. Let me show one example to begin with. This patient who presented with, it appears like a trigger, and he has undergone release of trigger finger in all the 4 fingers at some other institute. And as you can understand, patient came to us with triggering. That means with this release, it was not relieved. When you see carefully, this patient has a triggering which snapping comes at the MCP joint, not at the PIP joint. So this is not trigger. This patient had a dislocation of the extensor apparatus. So triggering classically happens only at the PIP joint. So if it is not at the PIP joint, it must be something else. You can see the difference in the videos. This is the PIP trigger and this is the extensor trigger, which is because of subluxation of the extensor tendon. And this is kind of blunders can happen if we take trigger release much easily. When you start doing the surgery, it is quite simple. The proximal border of the A1 pulley is marked, which is the proximal palmar crease at the radial border and the distal palmar crease at the ulnar border. A straight line, all the A1 pulley's proximal border is at this level. And the length of the pulley is about 0.98 to 1.2 centimeters for each finger. So that means about 1 centimeter on an average. So you make an incision here and you cut for about a centimeter. How you know that you have released the trigger completely? You will have a small gap which is called as C0 pulley before you reach to the A2 pulley. And be very careful not to be very aggressive, and A2 pulley must not be released because it is a very important pulley which prevents triggering of the finger, prevents bowstringing of the flexor tendon. So we must not cut the A2 pulley. Also, special care must be taken for the thumb because the digital nerves for the thumb, they are much closer to the flexor tendon. So if you are not right in the center, you may damage them. Also be careful about the radial sensory digital nerve, which is crossing the flexor tendon and going onto the radial side. So if you do a blind cut proximally, you may cause damage to the radial sensory nerve. So these are the very important points when you do release for the triggering for the thumb. The complications are incomplete release, nerve injury, and bowstringing of the flexor tendon, which can be quite commonly easily prevented by being careful and not to be aggressive and be careful of the nerve injuries. Some challenging conditions may look like trigger. So whenever you have doubt, do an ultrasound just to confirm that you are not having anything which more complicated to deal with. For example, a patient with partial tear of the flexor tendon can have triggering. A patient with synovitis can also have triggering. A patient with mass in the flexor tendon also can have triggering. So if you suspect any one of these, there is even mildest of doubt, do an ultrasound. Trigger finger in children is quite complex, and it is because of the congenital abnormal connections or contractures, and it should not be taken lightly at all. It is a totally different ghost at all. Then sometimes you will deal with a condition where even after releasing the A1 pulley, you don't get the release of the trigger. These patients tend to have triggering at the A2 pulley. We can release the A2 partially, but even after partial release, if A2, the triggering still persists, the best way to manage that condition is remove one slip of the FTS. And that would relieve the pressure in the compartment, the content in the compartment, and triggering will get relieved. As Madhu correctly pointed out, the ECU synergy test is a very beautiful test for EC extensor carpi ulnaris tendinitis, and one must very comfortable in doing this. It is quite specific and diagnosis is quite easy. As I told earlier, ECU sheath is very important because if ECU subsheath is not there, tendon will start subluxing whenever patient does pronation and supination. So for that reason, it must be reconstructed. So we can see over here the ECU subsheath. Because of the constriction, we can see the tendon is so thinned out at this place, and there was a lot of synovitis. We do release to decongest the space over there, but after that we should use the strip of the extensor retinaculum to reconstruct the ECU sheath, and also make sure that you don't make it too tight. And that is a very important part and very unique part of this type of tendinitis at the wrist when you are dealing with. Now coming to the commonest one, the dequerens disease. So when you are releasing the dequerens first compartment tendinitis, you could do it by a transverse incision or a longitudinal incision. The transverse incisions are quite cosmetic and hence are generally preferred. However, if you have a concern about there is more synovitis, then you can put a longitudinal incision because it gives a wider exposure. However, if you put a longitudinal incision, the incision is all along the nerve and there may be more tenderness in the scar. So it is preferable to put transverse incision. The incision is put about a centimeter proximal to the radial styloid and in line with the wrist creases. When you start opening the skin, the sensory radial nerve is just under the skin. Do not dissect it, because if you dissect, they tend to become more sensitive. Just leave it in the fatty tissue over there. Go proximal to the retinaculum and there identify the EPB tendon, which can be identified as having a small muscle attachment onto it. You pull it, the MCP joint of the thumb would extend. Once you have identified the EPB, then start dividing the first extensor compartment as far as possible, that is along the EPB tendon, because we want a long flap of this retinaculum there. The EPB, along EPB, the first compartment is released completely. And once you do a complete release, you make sure that you have this amount of good length of the extensor retinaculum, because this is important to prevent any slipping of the tendons onto the volar side. Be very careful because it is almost a rule that there will be multiple tendons of APL, and as Madhu pointed out, there are even 11 tendons have been reported in the literature, and almost always you will find that more than 2 slips are there, and they will be quite bulky also. Also very common is to have a separate compartment for the EPB. In fact, I think more than 2/3 of the patients who have a severe dequerence, especially young patients, would have a separate compartment for the EPB. So we need to be very careful and vigilant about it. Always look for EPB. A separate compartment over there, a nice thick compartment. So the surgery is not over till you have got the EPB, because EPB absence is very rare. And when you pull the EPB, you see this is the APL pull. When you pull the EPB, you will have an extension of the MCP joint of the thumb. That is the extension of the EPB. So once EPB is seen, the surgery is over. The complications which commonly can happen are because of the incomplete release, injury to the sensory radial nerve, which is, I think, the most scary thing of all, because it causes a lot of pain to the patient, tendon subluxation, and all of this can be easily prevented. But out of all, I think incorrect diagnosis is the most common problem. And we must make sure with all the tests which were described earlier that you are dealing with the correct pathology, that is the dequerens disease. So to conclude, when surgical treatment, then all the conservative treatment fails, you need to go for surgery, and it is the open release which is the most important thing. And I think one important point which I would like to stress over there is that whenever you have a patient, you try a conservative treatment, but don't keep trying that conservative treatment for very long, because surgeries are quite simple and quite gratifying at all also. Thank you so much.
Thanks a lot, Praveen sir. That was a very good, crisp talk. Most importantly, along with very vital videos what you shared, and the common complications which the regular orthopedic surgeons who are not trained in hand surgery can encounter. I think hand surgery has become very crucial now to understand the simple things which we all neglected all these years. But this was a very important talk, and especially with decurvin, so many fatal slips there, and releasing them, making it very important. And coming down to some case discussions, and I think Dr. Madhusudan has prepared some small cases, um, uh, important cases which can be very important in discussing here. So I'll hand over to Dr. Madhusudan again for some case discussions now.
Is my screen visible now?
Yes, Madhu, it's visible. You're also seeing, yeah.
Okay. Is there any way I can see the other speakers also? I'm not able to see them.
On the right-hand corner, you can just go there and check whether you can do that.
Yeah, the layout.
Layout, yeah.
Okay.
Now I think your screen sharing, yeah. You can share the screen, Madhu. It is coming as a small window there, along with your window there.
Yeah, I'll
And now
reshare.
this is better. That was better.
Is this fine?
1 second. Not able to see your screen. No, it is again half. Yeah. Now it's better.
Okay.
Yeah.
So good evening once again. I would request the other speakers also to keep their audio and video open. So to make this session more practical and interactive, I thought we could discuss a few common day-to-day OPD cases that all of us encounter regularly. And these are not rare or exotic diagnoses. In fact, they are the very cases that often create some confusion because of overlapping symptoms and mimicking pathologies. So the idea is not just to arrive at the diagnosis, but to discuss how we think through these problems, avoid pitfalls, and refine our clinical reasoning. So with that, I'll go to my first case. Yeah. So this is a 58-year-old right-hand dominant man who complains of painful clicking of the right ring finger for 5 months. The symptoms are worse in the morning. The finger occasionally gets stuck in flexion and needs to be straightened with the other hand. Increasing difficulty while holding kitchen vessels and gripping handlebars, no preceding trauma, and is a known diabetic for 12 years. He has already tried some NSAIDs and splinting with minimal relief. And this is a video of the patient. And when we ask the patient to flex, yeah, there is the first click and then the second click. And then when you ask the patient to straighten the finger, is not able to do that. And the finger can only be extended or straightened with the other hand. So that is the clinical picture. So I would request the speakers to give their input. What would be your diagnosis here? And importantly, what are your differential diagnoses? And what examination finding would confirm the diagnosis for you? Dr. Ajit?
Yeah. So, Madhu, as clinically, it looks like that the patient has a triggering. And so, important thing is that we should check that is the patient has any tenderness over the A1 pulley or not. One, any kind of clinically that the thickening of the pulley or any kind of nodes or something kind of that we should feel on the palpation. And it looks like trigger finger, but as you're saying that this is as if we go for the classification, probably it's a type 3 trigger finger where the patient needs actual extension by the other fingers, and diabetic patient also. So probably I'll go that it looks like a trigger finger of the ring.
Any inputs, Praveen sir?
Yeah, I think it looks like a trigger finger, correct? And I think for me, if there is any differential diagnosis, I will think if there is a tenderness at the A1 pulley and this type of feature is there and we are able to feel nodule, then the diagnosis is confirmed.
Yeah.
If any one of this is not good, then I will do an ultrasound.
Yeah.
Madhu, there was a trigger when flexing at the DIP joint also. So is there any possibility of a double trigger here?
Yeah, it can be called as double trigger actually, because while flexing, so that is where it takes us to the discussion by Dr. Praveen. So he was talking about that A2 triggering also. So there can be a component of A2 triggering in this case, and that is where the importance of ultrasound comes into practice. So anyway, going forward, so yeah, the differential diagnosis, yeah, the sagittal band injury and the extensor band subluxation. And like Dr. Ajit told, we also have to look for the tenderness localized to the A1 pulley region, any palpable triggering and the flexor region. And sometimes when you ask the patient, you can reproduce the catching phenomenon also. But most importantly, yeah, this is how usually the triggering can be. This is a case of a triggering of the thumb. And most importantly, I want to show this video. I think if you see the video, what was shown by Dr. Praveen, which is one of the commonest differential diagnosis for the trigger finger. So here what's happening is when you ask the patient to extend the finger and flex the finger, the triggering is not happening at the PIP joint like discussed in the previous session. And most importantly, yeah, this is a video. So if you look at the triggering is not happening at the PIP joint, instead it is happening at the MCP joint. And the patient is not able to extend the little finger. But once you passively extend the finger, later the patient is able to hold on to the extended finger. And that is where it points towards the sagittal band injury. Any points on this video, Praveen sir?
Yeah, I think this is what I showed, that surprisingly that patient has undergone 4 fingers trigger release.
Yeah.
So one of the main differentiating thing I think would be that patients generally will have that kind of symptoms in more than one finger. And they are having ligament laxity.
Yeah.
So these are the 2 common associates. So any patient who is not looking like a classical thing, I think these 2 are the thing. And obviously, if we see carefully, this trigger is only at the MCP joint. It will not be at the PIP joint. So we must remember that the triggering in the trigger finger is at the PIP joint and not at the MCP joint.
Exactly.
And
That
it is
was a
very
point.
interesting. All the patients with triggering at the MCP joint, they will show the volar side and tell that sound is coming.
Yes.
And the finger people, they show on the back side that it is paining
Yeah,
because they are not able to straighten the finger.
exactly. So it's
So
always important
can
to
be
check
quite,
both on the palmar
confusing.
side as well as on the dorsal side.
Yeah, so
Yeah.
we should.
Thank you, sir. I'll just, yeah. So do you routinely, because Dr. Ajit mentioned about the grade 3, so do you routinely grade trigger fingers in your clinical practice, or is it something we know academically but rarely document? And does the grade genuinely influence your treatment plan, sir?
So
For me, no.
Yeah.
Because there are many patients who may be having a grade 1, the so-called grade 1 trigger, and he is having only pain when he is flexing and it is not really triggering. So those patients also we will very often do a release. But it is a good thing to grade because at least you have one thought process as if whether you are like to, especially when you reach to grade 4 and all, that time there is no point in giving conservative treatment. So I think lower grades you can try conservative more often, and if it is grade 3, then you should directly go for surgery.
Dr. Ajit, you wanted to tell something?
yeah, I agree with Professor. So for me, what is important is that duration of the problem, since how many months he has triggering or the pain. Second thing is that is there any associated conditions are there or not, like diabetes, metabolic syndromes, or rheumatoid arthritis. Because rheumatoid arthritis or the diabetic patients, generally don't do better with injections. Probably these kind of patients require surgical interventions. But if it is acute condition and they are not associated with these, probably we should go for the conservative type of medications and injections. As I told that injection gives time to understand them. And I always believe that the surgery should be demanded by the patient rather than we should offer surgery to the patients.
Thank you. So that was a staging. What we do is called as a green classification for the grading. And does grading help predict steroid response? I think Dr. Ajit answered that question. And would you inject a grade 3 trigger finger in a diabetic manual laborer, particularly in this patient, Dr. Ajit?
No, I'll not.
I think that is one case where surgery should be offered to these kind of patients.
So there was one question, Madhu, in the group which we can answer now. What is the ideal sugar level when you want to do a steroid injection? So, Dr. Ajit, you can also answer that, sir.
Yeah.
It's a not basically if it is not the sugar level basically. What is important is that we should make sterility for the before giving the injections. An injection is indicated the grade 1 and grade 2. Grade if it is grade 3 and grade 4, probably the injection will not work. So ideally in the diabetic patient and diabetic also, if someone is recently diagnosed, you can give injections. But if someone has a chronic diabetic last 20 years, 10 years, probably the injections will not work.
Okay, sir. Thank you, sir. Thank you.
And Dr. Praveen, I think the first two questions you already answered. Coming to the third one, what do you do when triggering persists even after release?
Yeah. So if triggering persists even after release, then we should extend the incision and check whether it is because of the triggering constriction at the A2 pulley. And A2 pulley cannot be released fully. So if we are able to locate, okay, it is just in the distal part or in the proximal part, we can release half of the A2 pulley. Otherwise, easiest is to release one slip of the FDS. So that will decrease the content in the pulley system and the triggering will be relieved.
More likely like a debulking by excising one of the slips of the. And any preference of whether to excise the radial slip or ulnar slip?
Yeah. So I think it is not so much important which one you are exercising, but it becomes important only in patient with rheumatoid arthritis. So in patient with rheumatoid arthritis, you must excise the ulnar slip only, not the radial slip. Because if you excise the radial slip, those people tend to have increase in the ulnar deviation of the finger. So that is the reason for rheumatoid patients, we must excise the ulnar slip only. But other people, it does not matter. But when there is a choice between any one of the two, I think better is always to excise the ulnar one.
Even in normal and even in patients with
Even in
rheumatoid
normal
arthritis.
also.
Thank you so much.
Because the flexor tendons have a ulnar directed vector. So in case you excise that, no, you tend to have more deviation onto the ulnar side.
So that was a learning point from the case one. Not everything that triggers is a trigger finger, and exactly know where you are injecting. And that brings us to the site marking or the location of the clinical marking of the A1 pulley. And trigger finger release is simply only when everything goes right. And with that,
Madhu,
yes.
I want to convey one more message
Yeah, please.
in this forum is that whenever we are releasing the trigger finger, many times patient presenting after the surgery that the patient has a pain at the PIP joint. So the majority of the time, this pain happens because of the stiffness of the PIP joint, because of the persistent flexion of the finger. Patient has a stiffness of the PIP joint. So even after the release of the surgery, trigger will go, but the patient still have a pain at the PIP joint. So these kind of patients, we should always focus at the PIP joint. Little bit of stretching of the joint, and then patient will feel better with the course of time.
But that was a good point, sir. So with that, I'll go to the second case. Yeah, so this was a 68-year-old elderly woman, radial side wrist pain while opening bottle or key pinch, was treated for decurrent stenosynovitis in the past and was given steroid injection for the decurrent stenosynovitis 2 months back, but no relief, and she has come for further management. And how will be your the processor or the thought process in this patient? I'll give you some more information, but at this point of time, what is your thought process?
Yeah. So I think if there is no pain relief from the steroid injection at all, I will first suspect whether the diagnosis is correct or no. Because if the steroid injection was given correctly, all the patients should have some relief. So that is the first thing which comes in my mind. So I would other differential diagnosis of the dequerence we should be totally ruled out. And if they are ruled out and then the diagnosis is again confirmed with all the tests, then we can go in the dequerence pathway. If still any doubt is there, I would do an ultrasound. If all the clinical tests are positive, then I will assume that the injection was not given properly and go for surgery.
Yeah. So rather than starting with the decurrence pathway, go back and start with the radial sided wrist pain pathway. I think that will help in. So I'll give you, yeah, would you consider something other than decurrence? And yeah, so I'll give you some now. This is 68-year-old woman, pain while opening jars, difficulty turning keys, reduced pinch strength. Symptoms are there for 2 years and occasional night ache. And the tenderness, as I told, the tenderness is maximal at the first CMC joint. There was a positive grind test. The finger stage was mildly painful, but there was no clear first dorsal compartment thickening. Yes, now we start thinking because the location becomes very important. As we discussed, we start what is the pain distal to the radial styloid or proximal to the radial styloid. So this picture should be always kept in mind. And the X-ray was taken and this was the picture. So this case was mainly put to not to make the biggest pitfall that considering all the radial side wrist pain are decurvence, you look for the exact pathology and look for the exact site of tenderness. Any points, any inputs, Dr. Ajit?
Yeah, so the radial sided wrist pain, every inches the diagnosis differ. You starting from the intersection syndromes, then probably the recurrence, then the scaphoid waist fractures, then first CMC joint arthritis. So we need to know that what we are seeing, what we are looking for, where exactly the patient has a tenderness. So that is and as the age is a factor, tenderness over the CMC joint, grinding test is positive, X-ray is showing sclerosis and arthritic changes. So all those things go in the favor of for CMC arthritis.
So that was a learning point. Not all the radial side wrist pain is decurrence. Location of the tenderness, as Dr. Ajit mentioned, is very important. And don't rely on the previously made diagnosis. You go back and start from the beginning, and that is when you don't get biased. And can I go ahead with the third case, Dr. Santosh?
Madhu will ask some questions which have come up in the chat box, and then if we have time, we can go with the third case.
Yeah, definitely. There is only one case left, so
Yeah,
we'll take the question and answers.
Yeah, the most important. What is the major difference between the tendinopathies of the usually you see like the tennis elbow or the cuff tendinopathy, shoulder tendinopathy, gluteal tendinopathy, wherein the rehabilitation plays the most important part. Neither the injections nor the surgery is usually considered, but mainly rehab. But in the talk we had today, there is a lot of role of basically steroid injections, and if not doing well, we also go ahead with a surgical procedure. So, how different are these tendinopathies, the hand tendinopathy, especially the decurvence and the trigger fingers, considered to tennis elbow or gluteal tendinopathy or the rotator cuff tendinopathy or Achilles heel tendinopathy, which are the common tendinopathies we see? And there, the crucial role, 80 to 90% of the patients are put into rehab basically. And fewer roles are there of steroid injections, especially in TA tendinopathy. You don't give an injection. In shoulder also, you try to give it very minimally. So how different are these tendinopathies? These questions are all the panelists. I mean, everyone can answer. Anyone can answer.
Santosh sir, can I come?
Yes, yes, sir.
Yeah. So tendinopathies of the hand are the stenosing. They are influenced by, or they are affected by, or whatever you say, that there's some kind of band is there. In decurvence, the first extensor compartment is there. In the trigger finger, there's a A1 pulley is there. So they are the stenosing tenosynovitis, while the other tenosynovitis like lateral epicondylitis, tennis elbow, rotator cuff, or the TA, they are the purely inflammatory and they are repetitive stress syndrome kind of that, rather than the stenosing. So probably for me, this is the major difference what we find in the hand and the other tendinopathies.
So any role of exercise therapies in your things? What is the conservative role other than NSAIDs and splints? Anything else can you give? Like, for example, in the other tendinopathies, commonly a lot of nutraceuticals like collagens and everything is given, which work to some extent, which have some of the studies have also shown. Probably in the long run, they say that the pain benefit is same as equivalent to diclofenac as well as the collagen. So collagen fares better. But is there any role of these kind of supplements in your tendinopathy, sir?
For me,
Uh,
so
mean,
actually, yes, sir.
no, no, no.
So
Continue, sir. Continue. Sorry.
yeah. So the culprit is the band. The culprit is banned. And if you will keep moving, if you keep doing rehabilitation kind of things probably it will be worsened. My teacher used to say that if someone is angry, keep him in the same separate room. He will be cooled down and he will be fine. So it is kind of that all the tendons, whatever is there, they become angry because of the repeated that band and all those things. So if you'll give rest, probably they'll feel better. If you keep, that kind of rehabilitation or the physiotherapy, probably it will be worsened. So, and other places where the rehabilitation is required, it's kind of, it's increasing the blood supply so that the inflammation gets settled down, and it's a kind of collagen fibers which changes from one form to another form because of the stress over so the things are completely different.
Okay. Yes, Madhu.
Yeah. So I want to come back to that question of tendinopathy, how different is the tendinopathy of hand from the tendinopathy? And when I say that, if you want to differentiate between the lower limb tendinopathy, for example, the Achilles tendinopathy or the patellar tendinopathy, there the pathology is predominantly because of the failure of the tensile loading. But in hand, it is not because of the loading. It's mainly because of, like Dr. Ajit mentioned, either it's because of the bending or because of the slip, some stenosing, some constriction. So that is where the pathology is. And even then, that's why histology wise also, when you look at the patellar and most importantly in the hand, all the tendons, most of the tendons are covered by the synovial sheaths. And these synovial, unlike in Achilles, there you don't have a synovial sheath, there you have a paratenon. So here synovial sheath is almost covering the tendon, and any fluid collection, there is no space to escape. So even minimal fluid collection will have symptoms. And that is the reason why the treatment also is different. So in Achilles tendinopathy, the treatment is mainly regarding the increasing the tolerance of the tendon. But here in hand, we are not doing that. Here, what we have to do, release the constriction, make the tendon free, change the path, and that is how we have to. So even because of the pathology, the management also changes from the lower limb tendinopathy to the tendinopathy around the hand and wrist. Yeah, thank you.
Thanks, Madhu. That was very important. And one more question has come up. Is steroid your choice, or now PRP is being propagated more commonly? So does PRP play better role than steroid, or you still hand surgeons stick to steroid injections? Praveen sir and Ajit sir also, please can put your experience matters most here.
Actually, we have never used PRP, but I believe the people who have used, they have found that the results are almost the same.
Are the results as quick as steroids, sir? But as we find, like steroid injections do start working within few days. But the PRP, as the analogy goes, or according to the textbook, it should start acting in few weeks later. It's not like 1 or 2 days it starts acting. So, have you tried personally PRP injections, sir, or you go only with steroid injections?
No, we have not tried PRP.
Okay, sir. Thank you. Madhu, your experience?
Yeah, actually, we started using PRP for a few patients, but it doesn't give that dramatic relief, because once we give steroid to the patient, patients are immediately very happy because their pain disappears and they know, okay, some magical thing has been done. But PRP doesn't give that feeling to the patient. But on a long term, yes, they're having good relief. But with a very less patients, I don't think I have anything to comment on that.
Okay. Thank you.
Dr. Ajit, you have used PRP?
No, sir. We also don't use PRP. I completely agree with you and Praveen, sir. So we give only steroid injections. We haven't tried.
Okay. Okay, Madhu, I think we can have one more discussion of your case now. Madhu, I think we can have one more discussion.
Okay, so I'll just finish this. This is the
I
last
can
case.
do-
So a 52-year-old, you're able to still see my screen?
Yeah, we are able to see.
Yeah. So this is a 52-year-old recreational tennis player who complains of pain over the ulnar side of the wrist for 4 months associated with pain. Associated with swelling. Pain increases while hitting backhand shots and lifting heavy objects. No major trauma. Treated elsewhere as TFCC injury with wrist support and NSAIDs. At this point, what would be your differential diagnosis? Number one, would you already suspect ECU pathology clinically, or would you still need imaging in these patients? Praveen, sir?
Yeah, I think the differential diagnosis for a player with this type of pain, common would be the TFCC tear. And so suppose my clinical examination, that is the point of tenderness, is at the ECU and not in the fovea, and the ECU synergy test is positive, then the diagnosis of the ECU synovitis tendinitis is confirmed, and I may not do MRI, do only ultrasound.
Yeah.
But if there is a foveal tenderness, then yes, MRI is required.
To look for the TFCC or intra-articular pathologies. Yeah.
Yeah.
So these
Because
are
sometimes
but
the
this patient,
TFCC and ECU both can be coming together. They are
Yeah.
like friends.
so that's why just to mention that that's why the ulnar side wrist pain in hand is called as the back pain of the wrist. Yeah. So that this patient had tenderness over the sixth dorsal compartment and pain worsens with forearm supination and resisted wrist extension. ECU synergy test was positive, but there was mild discomfort with TFCC low test also in this patient. So does a positive ECU synergy test make you stop looking for TFCC pathology is the question. And can ECU tendinitis and intra-articular pathology coexist? What do you say, Dr. Praveen?
Yeah, I think they commonly coexist. In fact, the long-standing TFCC tear is one reason for patients to have ECU synovitis,
Okay.
ECU tendinitis. So that can be secondary to the old TFCC injury. So if there is anything more than the ECU level tenderness, we must do MRI to make sure that it is not just secondarily because of that, and we may treat the ECU and then again it will have the same symptoms again.
And so the ultrasound was done, and there was some fluid collection around the ECU tendon in this patient. Like you mentioned, we don't routinely do ultrasound because even I for this MRI, this is how it might look. I have taken from the internet for this picture because we don't routinely do MRI for when we suspect clinically the ECU tendinitis. So where exactly do you inject? I think Dr. Ajit has mentioned in his video on injection. And what is your indication for surgery in ECU tendinitis? I think this is the important question, Dr. Praveen.
Yeah, I think indication for ECU tendinitis release is if the patient does not get good relief with one shot of steroid injection. And if the symptoms persist, after steroid injection, we should routinely put them on a slab in mid-prone position, not in supination, mid-prone position, because in supination, the ECU is more taut.
Yes.
So we immobilize in mid-prone position and then for 4 weeks, and after 4 weeks, a gradual rehab and improvement of the range of movement. At 2 months, when the patient start using the hand, if there is again pain, then we should think of doing the release of the ECU sheath. And as I mentioned, this is one of the tendinitis or tendon stenosing tenosynovitis in which we must reconstruct the sheath again.
Yeah.
So once the ECU is released, it may start becoming very unstable. So we should make sure that some kind of stabilization process is done.
And in the picture, what you've shown of the reconstruction of the sheath, you had kept a nerve loop within the tunnel. Is it
Yeah.
because you don't want to over tighten the sheath?
True, yes.
Yeah.
So we should have something inside the vessel loop or the feeding tube or Riles tube, just to make sure that you are not making it too tight again.
Thank you, sir. Yeah. So that is the end of the cases. Over to Dr. Santosh.
I think we had a very elaborate discussion about the conditions what we are encountering in day-to-day practices. And most important thing was how other tendinopathies and hand tendinopathies, commonly encountered tendinopathies in hand, are quite different from the regular tennis elbow or Achilles heel, what we feel or what we see in our practice. And this leads to like quite a confusion on how to treat. So treatment is also quite different. It's like completely two different scenarios. Here it's rest and mainly wait for the response to happen. The body should heal by itself. And in other scenario, you have to initially rest for some time, but again you have to start rehabilitating, which involves a lot of other exercises. But here it's mainly rest, which in hand tendinopathies, and most likely they may not improve with conservative treatment because hand, as Madhu said, is like it is undergoing suffering because of its own expertise, like repetitive movements and all. The Madhu's first talk was very important in mentioning how important the hand function is, and you cannot rest the hand for a longer time so that the livelihood is again taken off. So I think the interventions play a vital role in these tendinopathies, and hence I think the management completely changes. And now I think we'll close this session. I think I'll invite Chahal sir, who is our vice chairman of Department of Hand Surgery in Gangarama Hospital, and he's also the, as Alex sir mentioned, the ANBI coordinator, academic coordinator, and the Delhi chapter secretary. Over to you, Chahal sir.
Thank you for the kind introduction. Respected faculty members, distinguished guests, colleagues, and dear participants. On the behalf and by the organizing team, it is my proud privilege to propose a vote of thanks for today's highly enriching webinar on wrist and hand tendinopathy masterclass, evidence, experience, and evolving techniques. First and foremost, I would like to express a heartfelt gratitude to Dr. Alexander Thomas, Senior Consultant, Orthopedic Surgeon, and founder and patron of NBI, for his inspiring welcome note, constant encouragement, and unwavering commitment towards academic excellence and medical education. A special word of thanks to Dr. Santosh Angadi, Head of Department Orthopedics at the Bangalore Baptist Hospital, for a wonderful moderating today's session and seamlessly steering this highly interactive and academic discussion. I extend my sincere gratitude to our eminent keynote speakers, Dr. Madhusudan, Dr. Ajit Tiwari, and Dr. Praveen Bhardwaj, for their outstanding academic talks, insightful presentation, and sharing of their invaluable experience on this extremely important subject. The wrist and hand are among the most functional units of human body. For every working individual, they are not merely anatomical structures, but instruments of livelihood, productivity, and professional capability. Whether one is a laborer, an artist, an engineer, a surgeon, or a physician, hand functions defines efficiency and independence. A large number of these tendinopathies and related disorders arise from repeated stress, overuse, poor ergonomics, and occupational abuse. Today's masterclass has greatly enhanced our understanding regarding the prevention, early recognition, medical management, and surgical management in these conditions. As healthcare professionals and surgeons ourselves, we understand that even a seemingly small condition, whether a ganglion decurvance or a tendon pathology, can significantly impair professional performance and put a surgeon or a physician out of action for a prolonged period. Therefore, awareness and timely management becomes critically important. I would also like to place on record our sincere appreciation to PharmEd for organizing this excellent academic initiative, spreading awareness among healthcare professionals, and efficiently managing the logistics of conducting this webinar on such a large scale. Finally, I thank all the participants who joined today and made this session interactive and meaningful with their enthusiastic participation. We look forward to your continuous support, participation in many more masterclasses and academic endeavors in future. NBI remains committed to promoting education, advancing clinical learning, and staying at the forefront of medical education training for our students and healthcare professionals. Thank you once again and wish everyone a very good evening.
Thank you. Thank you, everybody.
Thank you, sir. Thank you all.
Thank you, doctors.
Thank you again, one and all. And I request the same attendance would be happening for further of our webinars, which will be coming in future. Thank you, one and all. Thanks again. Thank you, Alex sir. Thanks a lot. Thank you, Madhu, Ajit sir, and Charles sir. Praveen sir.